full-time professor at Monash University. It's been a very exciting first 6 months at Monash, establishing the Department of Diabetes. What I'd like to do in this presentation is give you a bit of an overview of our work and its context in terms of the current management of diabetes and its complications. And importantly, I want to emphasise that we're really at a very exciting period in the treatment of diabetes, because for the last 100 years, we've been using the same drugs and same management plan, and in the last 5 years, we've suddenly changed the way we treat this condition. So it's really been a great success the last 10 to 15 years in the management of diabetes, because the major burden of diabetes is indeed the complications. And when people ask why you treat type 1 or type 2 diabetes, obviously we have to manage the hyperglycemia, but more importantly, we want to reduce the ultimate poor outlook as a result of complications. We have a second, also other important agenda, which is particularly in type 2 diabetes, the patients want to avoid going on insulin. And we've really had pretty pathetic approaches to stop people when they develop diabetes, that most of them after 10 to 15 years end up on insulin. But the situation is changing. And you can see here there's been a dramatic reduction in the prevalence of myocardial infarction and stroke. We've had less impact on peripheral vascular disease with amputation, and kidney failure, the major interest of our group, has really been pretty disappointing. But probably the benefits on myocardial infarction and stroke have not been related to improved management of diabetes, but related to the comorbidities, dyslipidemia and hypertension, which we can treat much better than we could 20 years ago. So I'm just going to show you some historical slides initially about how we got into this area. And really it starts 30 years ago when we decided to do a very simple project, which was to look at the importance of hypertension itself in the progression of diabetic complications. And Terry and I worked with Ostendahl and George Jerems, and we created an animal model of diabetes with associated hypertension. And surprisingly, when you induce diabetes in spontaneously hypertensive rats, you saw a dramatic increase in the development of proteinuria. And this was associated with structural changes at a morphological level, and that ultimately we looked at some of the molecular changes and discovered depletion of a key protein known as nephrin, which has been shown to be very important in the development of proteinuria. About the same time, there had been some interest in the potential role of certain blood pressure lowering drugs, and we administered an ACE inhibitor and showed big reductions in albuminuria, not only in the hypertensive animals, which are in the red, but also in normotensive animals. So suddenly we saw that blood pressure lowering, even in the setting of a normal blood pressure, was useful in the setting of diabetes. And this transformed the way we managed diabetes at the time, and we stopped being so glucose-centric and started looking at the other comorbidities, and in particular started to aggressively treat blood pressure, even in people with normal blood pressure. Subsequently, we showed, Terry Allen showed, that angiotensin II receptor blockers could confer the same benefit that we saw with ACE inhibitors, emphasising the particular role of angiotensin II. And indeed, in a large clinical study that we were involved in, we were able to show that the angiotensin II receptor antagonist losartan could slow down the doubling of serum creatinine, and in particular reduced end-stage renal failure by about 20%. Now that's not a very spectacular result, you might think, but till that time, no drug had ever been shown to have any impact on kidney failure, which some of you may not appreciate is a very expensive condition requiring dialysis or transplantation, and costs, just by delaying kidney failure by 12 to 18 months, you're saving at least $50,000 per patient. Subsequently, we thought that maybe these ACE inhibitors or angiotensin II receptor antagonists might do more than just be beneficial on the kidney. And although I won't explore it in a lot of detail, Jennifer Wilkinson-Burkett showed seminal studies in retinopathy showing that the renin-angiotensin system played a critical role in the retina, and indeed these agents could reduce proliferative retinopathy, which has subsequently been confirmed in clinical studies. We wondered about the potential role of these drugs in atherosclerosis, because as we heard this morning, one of the big problems is we often don't have very good animal models of the diseases we want to study. And in particular, we had no animal model of diabetic atherosclerosis. We'd seen a paper in Nature Medicine inducing diabetes in ApoE knockout mice, which suggested that after 8 weeks, there was increased atherosclerosis. We were unable to reproduce that data in Nature Medicine, but subsequently, by tweaking with this model, we could show that after 20 weeks, we had a robust effect of induction of diabetes. And if you have a look here, this red staining is atherosclerosis. You see a little bit of staining in the arch, thoracic and abdominal aorta in the control animals, but what you see in the diabetic situation is a marked increase in atherosclerosis, but not only do you see increase in the arch, but you see a much more diffuse pattern of atherosclerosis, which indeed is the same as is seen in clinical medicine. And a cardiologist will tell you when they do an angiogram, they can often tell that the patient is diabetic by seeing much more diffuse disease than is normally seen in the non-diabetic population. What was truly remarkable was that the administration of the ACE inhibitor, essentially in the context of not reducing glucose at all, and these animals have glucose levels between 25 and 30 millimoles per litre, we could see a marked attenuation of atherosclerosis. This has subsequently been confirmed in clinical studies, and this is just showing you the HOPE study, where you can see here, if you have a look, the ACE inhibitor group is the yellow group, placebo is the black group, and you can see there's a reduction in myocardial infarction, stroke, cardiovascular death, and indeed all death, and a reduction in heart failure, and a trend towards reduced kidney disease, reproducing what we had predicted from the animal studies, that blocking the renin-angiotensin system has both cardiovascular and renal benefits. And so we believe that the big reduction that we've seen, particularly with respect to cardiovascular and cerebrovascular disease, is due to the widespread use of blockade of the renin-angiotensin system and statins. But we still have this refractory problem, particularly of kidney disease. So even though complications as a percentage for patients are reducing, the problem is the diabetes continues to explode. And you would be aware that Paul Zimmert, who's in our department, was really one of the first people to mention or suggest that there was this worldwide epidemic of diabetes. And you can see here the progressive increase in the number of people with diabetes in Australia, which has continued to increase. And you can see over here, we think at least 2 million Australians probably have type 2 diabetes. So even though the risk of complications per individual is decreasing, the overall health burden is not decreasing. And if you calculate, this is based on US data, you can see here that if we look at the prevalence of type 2 diabetes, it's increased at least 50% in the last 20 years, and this has led to a similar increase in chronic kidney disease. So chronic kidney disease represents more than 50%, type 2 diabetes represents more than 50% of people in dialysis and transplant programs now, and remains a major problem and an unmet need. So the burden of complications looks extremely high. It's $1 trillion worldwide, and 1 in every $9 is spent on diabetes, and in particular on its complications. And if you actually look at the cost of the management of diabetes, the drugs we use to control sugar represent less than 10% of the cost, and the cardiovascular and renal and amputation represent probably 70% of the cost. So our group is focused particularly on finding new ways to reduce the burden of these complications. So it really is a very exciting time in diabetes. If you have a look here, insulin, it's almost 100 years since the discovery and introduction of insulin. In the late 30s and then in the 50s, we introduced sulfonylurea and metformin. And really, even when I was a young consultant, these were basically the drugs we were using. And as you can see, then there was a big change in the types of insulin that were used, and they have not been a dramatic advance really in the management of diabetes. And subsequently, particularly in the last 5 to 10 years, there's been a dramatic increase in the number of new drugs, and in particular the DPP-4 inhibitors, the SGLT2 inhibitors, and the GLP-1 analogues appear to have transformed the way we manage diabetes. So what does the future hold in diabetes? I'm just going to show you a slide from the American Diabetes Association where there was a review of all the research. And I want to emphasize that everybody seems to be very interested in big data and all these databases and e-health and precision medicine. But it looks like, although we generate data very quickly, its contribution currently to the modern management of diabetes is minimal. We already know from all the databases who will get the complications. We know it's particular increases with age. We know that people are getting diabetes at a younger age. We know Indigenous populations seem to get a lot of diabetes and the complications. But where the big advances seem to have occurred is understanding at the level of the organs where the complications are, in particular in the heart, the brain and the kidney. And the new drugs are having a dramatic transformative effect on the burden of these complications. And I think that it's very important to appreciate that although we have a lot of exciting technology, genomics, epigenomics and whatever, still the understanding of physiology, biochemistry, metabolism are particularly important in a condition such as diabetes where the primary abnormality is an elevation in glucose. And I think we've forgotten that glucose is a very reactive substance that can do a lot in the body, and we need to try and work out why glucose is so dramatic in its effect on the kidney, the heart, the retina. And so that's been the focus of our research. How is it that glucose, blood pressure, and weight gain are leading to all these complications? And that's what we've been doing, trying to identify these pathways and identify particular targets that could potentially become new therapies for reducing the burden of diabetic complications. And I'm just going to give you a few examples of how we've worked at the basic and fundamental level and then moved to clinical. So one of the targets that we identified very early on is the potential role of oxidative stress in the diabetic setting. And in particular, it was identified that NADPH oxidase, and in particular this family of enzymes, plays a critical role in the diabetic situation. Now, there are many sources of reactive oxygen species in the body, but the one particular family that's primary role is to generate superoxide is NADPH oxidase. And many of you would be aware of NOX2, which is indeed the enzyme in neutrophils that generates superoxide to fight infections. Now, we know that diabetics are very susceptible to infection, so that would be a particular isoform that we would want to avoid to block. And indeed, this was done, Karen Yandlai-Dam did this. We had access to a range of knockout mice, NOX1, NOX2, NOX4 knockout mice, and we were able to induce diabetes in these animals and showed that in that diabetic milieu, the NOX1 knockout animals, when we induced diabetes in those animals, there was reduced atherosclerosis. Furthermore, we had access to an inhibitor of these NOX isoforms called GKT, and this reproduced the anti-atherosclerotic effect of this that we had seen in the NOX1 knockout animals. And indeed, we've just had about 2 weeks ago approved a combination of Genkitex, a company, and the ARC and JDRF Australia are going to support a clinical trial which will be based here on this precinct to recruit 150 type 1 diabetic patients who already have early renal disease, who are already treated with optimal care. that is blockade of the renin-angiotensin system, and they will be randomised either to the GKT compound or to placebo. And this is an example of where the animal work that was done by our group has ultimately translated to a new clinical trial. Now, one of the other important targets in diabetic complications is trying to reduce the fibrosis that we see particularly in the kidney, where we see progressive scarring in the kidney, which leads to a reduction in renal function and ultimately renal failure. And the main cytokine or growth factor that's thought to be implicated in this fibrosis is transforming growth factor beta. But unfortunately, transforming growth factor beta has turned out to be very difficult to directly target. Antibodies to TGF-beta have very high side effect profile, and when you reduce the dose of the antibody so that you don't have the side effects, it appears to be ineffective in diabetic nephropathy. So we've tried an alternative target where we've identified a protein which seems to act in synergy with TGF-beta to promote kidney fibrosis. And this is work that was done by Dr. Chai, where not only did we identify that this protein was upregulated in the diabetic kidney, but he was able to identify the receptor for this protein and show that when CDA1 binds to its receptor, it activates classical post-TGF-beta receptor signaling pathways, including phosphorylation of the SMADs. And this promotes fibrogenesis. And in studies where we've knocked out CDA1 or CDA1 binding protein, we see reduction in diabetic kidney disease. Now, to try to block that phenomenon, we've generated a peptide which can interfere with the binding of CDA1. And indeed, in animal studies, we've recently shown that administration of this peptide indeed reduces diabetic kidney disease. Now, you would say a peptide may not be an ideal approach for the treatment of complications of diabetes, but you need to appreciate that diabetic patients are often receiving injectable compounds. They receive insulin, GLP-1 analogues. So in contrast to many other diseases, diabetics are not averse to having repeated injections to reduce the burden of their complications. So indeed, we've shown with this protein that it's upregulated in the diabetic kidney, it leads to increase in fibrosis, and that knocking out this particular protein leads to less kidney disease. And recently we've shown that administration of this peptide reduces complications. And we're currently, in collaboration with pharmaceutical companies, trying to generate either an oral version of this inhibitor or maybe a longer acting version of this peptide that is more stable, that could be administered less frequently than the current 2 to 3 times a week. So I've tried to emphasise to you how glucose promotes diabetic complications. And although I've downplayed the role of genetics, which has been relatively disappointing in the field of diabetic complications, we do know that diabetic complications involve a gene-environment interaction, and that most people with diabetes will not develop the complications, probably only maybe a third. So could there be an interaction between the effects of glucose and the genetic makeup, which could potentially be related to epigenetic pathways? And this is work that I've been working with Samuel Oster for more than a decade, identifying various epigenetic pathways and their potential role in diabetic complications. So it's clearly more than our genes. So epigenetics, how we explain the concept of epigenetics is often misunderstood by people, but I think the simplest way of thinking about it is that it represents pathways that can explain at a molecular level interactions between the genes and the environment. And indeed, what we've done, this is actually studies that Sam has done in collaboration with our collaborator, Professor Henrik Group. He has a group of 6,000 type 1 diabetic patients in Finland who've been very extensively genotyped and phenotyped with respect to diabetic complications. And we've obtained circulating mononuclear cells from these patients and indeed shown that as the patients go from healthy to normoalbuminuria to progressive increases in kidney disease, we see on the right a reduction in DNA methylation. And indeed, in particular, you see a reduction in DNA methylation of mTOR, which is considered a key nutrient sensor that is particularly relevant to signalling of glucose and insulin, and is a logical potential explanation for the gene-environment interactions that we see in diabetic kidney disease. Furthermore, Sam identified that there was an alteration in histone methylation, and in particular, changes in methylation of the 4th lysine on histone 3. And this change, or this histone modification, occurs as the result of mobilisation of a specific histone methyltransferase known as CET7. And you can see here, in diabetic animals, you can see that this monomethylation in the promoter region of NF-kappa B, the P65 subunit, is increased after high glucose for 16 hours, and it persists even after the cells have been returned back to normal glucose. And although I haven't discussed this in detail, one of the classic phenomena in diabetic complications is a phenomenon known as hyperglycemic memory, which is that periods of poor glycemic control can, for many years later, even after the patients have returned to good glycemic control, lead to an increase in diabetic complications. And we believe that this memory, these epigenetic pathways, could be conferring this metabolic memory. And it could be as a result of mobilisation of this enzyme CET7. And you can see here that when we have high glucose in the CET7 knockdown cells, we see a prevention of this histone 3K4 monomethylation. As again and again in that memory situation where you've had the glucose return back to normal, again you see in these CET7 knockdown cells a prevention of this epigenetic change. So we believe that this enzyme plays a critical role in metabolic memory and could potentially be a target as a new treatment for diabetic complications. So what we have today is we know to prevent the burden of diabetic complication, that reducing glucose, and I haven't talked in detail about the benefits of some of the newer drugs, reducing blood pressure and reducing cholesterol will make an impact. But it only reduces at most 50% of these complications. So what we're hoping in the future is that some of those targets that I've just briefly mentioned today are the targets of tomorrow, and if you have specific treatments to reduce the pathological pathways and the deleterious effects of hyperglycemia, we could further reduce the burden of diabetic complications. So if we can prevent these complications, we believe the patients will do very well. If you look at type 1 diabetic patients who have kidney disease, as they have increased kidney disease, you see an increase in mortality. But if a diabetic patient does not develop kidney disease, they have either reduced or at least normal lifespan. We think there's actually a reduction in a better outlook because we're treating all the risk factors for other complications as well. This phenomenon is also apparent in type 2 diabetes, that if you have the patients without renal disease, they do very well. So our own view is that if we can reduce the burden of diabetic kidney disease, not only will we see less people progressing to end-stage renal failure, but the overall outlook, particularly in cardiovascular disease, will also be improved. So finally, these are the PIs from the new Department of Diabetes. We invite you to see our new laboratory. We thank Monash for building really a spectacular laboratory, and I'll stop there. Thanks very much.